Thank you, Mr. Chairman. Thank you, dear colleagues. That's a privilege and honor for me to be here. And actually, the topic assigned to me is to compare IVUS versus OCT. But I have a very big conflict of interest to declare that I have an enduring deep belief that angio is not enough. So whatever we do with angio, we are sure. So I think the right question for the current era is to be when to use intracoronary imaging versus angiography. So the issue is not OCT versus angio versus IVUS, it's the issue of imaging modalities versus angio. And let me give you a piece of evidence. This is from the Renovate trial mentioned by Dr. Ashraf and shows clearly that image-guided PCI is far superior than angiography-guided PCR, especially in terms of death and from cardiac causes, nearly double the rate. And the conclusion was that intravascular imaging as a whole reduces the TVF and cardiac death significantly at 1 year. A larger bit of evidence comes from the updated network meta-analysis, nearly 12,000 patients who also compared imaging, OCT, IVUS, whatever you choose, versus angiography. It's a randomized trial, 20 centers, and without doubt, it showed a target lesion failure reduction about 31%, cardiac death lowered by 46%, TVI, MI, TLR, all decreased by nearly 1/4. Also, the acute parameters in terms of stent thrombosis, all MI, all cause death, all had significant reduction. So the message is clear. Choose it, be it OCT, be it IVUS, both increase the stent area, decrease the target lesion failure, reduce the major adverse events, and increase the outcome for patients. So decide whichever modality you want. Intravascular imaging, choose the most one that is suitable for the patient and for the lesion. We can use both IVUS or OCT in many situations. PCI planning, for example, determining the morphology, length, stent sizing, PC optimization, and left main PCI in some cases, also to delineate the mechanism of stent failure and stent thrombosis. I'll not go in details through this because Ziad at the end of the session will give you a very detailed, I'm sure, insight about this. But there are some situations that we really can prefer one over the other. So with IVUS only, we can choose IVUS if we have a problems with the kidney, if we are opting for zero contrast PCI or ultra low contrast PCI in cases of aneurysms or ectasia, if we really need a real-time guidance through, during the procedure, like if you are wiring an aortoosteal stents, if you are doing a complex CTE wiring, or you are using a real-time IVUS to position the stent in some osteal lesions if you need to do so. Also, if you have no contrast passing through the lesion in terms of subtotal occlusions, very tight lesions, also IVUS would be preferred. On the other hand, OCT mainly is preferred in patients with ACS and ambiguous or discordant angiographic findings. You have a patient with ACS, typical pain, troponin elevation, and then you take him to the cath lab and you find normal coronary arteries. This is the patient where you need to push or to put your OCT probe in and look for the pathology. Also, any intraluminal structure that is ambiguous, haziness, also OCT would be, I think, in my opinion, preferred than IVUS in this particular situation. If you are using bioresorbable scaffolds, also OCT is far superior than IVUS in looking at the specific peculiarities of the device. Of course, one of the main advantages of OCT is 3D reconstruction, and I'll show a couple of examples for this, and stent malformation in particular is one of these. If you choose IVUS or OCT, you are doing okay in most of the cases. 80 to 85% of the cases with either modality, you will do fine. However, you will only need to prefer one over the other in like 10 to 15% of the cases. As we said, for PCI planning and optimization, choose OCT for the MLED max or choose IVUS for IVUS 1 to 3, you will do okay, no problem with this. But in some situations when you need a real-time IVUS wiring of osteal stent, for example, this is a patient with sub-stent wiring in an ostial left main location. And as you can see here, in the very initial part of the stent, the IVUS showed that we are sub-stent. The solution is to use the IVUS in the same place to try to rewire with live guidance and real-time guidance the main lumen of the stent. As you can see here, the wire in the true lumen under real-time vision. This is one of the peculiarities of IVUS. Again, large vessels, large aneurysms with thrombi, an area that IVUS excel in because of the low penetrability of OCT. In CTO, this is again a good playground for IVUS. The first application that we can use is to solve an ambiguous cap. As you can see here, a diagonal with total occlusion of the LED with no apparent cap. You put the IVUS, try to search where the cap is, and under direct real-time guidance, we can try to penetrate the cap. And as you can see here in the lower right corner, the wire is seen just negotiating the cap during real time. And when you do this and go within the normal cap, you have your way, and the rest is a usual PCI procedure. The second application is ordinary wire positioning. You do a CTO, anti-grade wiring, and then when you do IVUS, you find that the wire is, of course, in the subintimal lumen, and they find that the true lumen is here, like as you see at 11 o'clock. So you can use the IVUS just to rewire and make sure that your wire now is in the true lumen and complete the procedure with an intra-plaque course. As you can see here, the wire in the true lumen after repositioning. And also, you can use your IVUS to control and optimize your procedure at the end. Another application is to target retrograde true lumen reentry. This is a retrograde trial. So retrograde true entry is assessed in this particular case with direct visualization, real time, targeting the IVUS in the antegrade true lumen from the retrograde subintimal wire, as you can appreciate here, and make sure that your wire finally is in the true lumen. This is followed by optimization and externalization and the rest of the procedure, and to use the IVUS for control. OCT, on the other hand, excels in some positions, like defining the common phenotypes in ECS. It beautifully demonstrates the plaque rupture, beautifully shows you the plaque erosions, which is responsible for 1/3 of the ECS patients, and of course can classify the different phenotypes of calcified nodules that are responsible for nearly an average of 5% of cases of STEMI. Plaque erosions is beautifully demonstrated, and one of the cases that I like to see, because you can defer stenting if you put an IVUS in this patient and detect the plaque erosion. This is suitable for the patient because you can defer stenting and treat him medically. The fibrous cap, the vulnerable plaque, the cavity formation, the plaque rupture, all of these are very uniquely demonstrated by the OCT. One of the peculiar modalities derived from OCT is the 3D bifurcation stenting, and here, as you can see, this is a two-stent technique with, after putting the side stent, you need to recross, but you would never be sure which cell that you cross through, except if you have a very high resolution modality like the OCT, and you can, of course, detect here, like in the bifurcation, that your wire is truly or not through the distal strut, and here it was not. So because we used the 3D OCT to make sure that we are in the 3D in the distal strut versus the proximal one, and this is where you want actually to be. So it enables you to select the cell that you want to wire, and then after recrossing, after kissing balloon, again you need to make sure that after crushing and putting the second, during the second rewiring, you need also to see if you are in the distal strut or not. And for this 3D reconstruction, as you can see here, we are passing in the distal cell to achieve an optimal polygon of confluence shape at the end of the bifurcation stenting. Finally, for the BRSs, as you can appreciate here, this is a free-solve scaffold that was deployed across a diagonal, and during trial of rewiring the diagonal, you see here, we had some resistance in passing the balloon, and as you can see here, you have the wire, as shown by the OCT, is passing behind the struts of the scaffold and causing some deformation, which in angio was not absolutely detected. 3D reconstruction confirmed this, and as you can see here, the wire passed from the very initial cell, went outside the 3D of the stent, the struts of the stent, and passed to the diagonal from a substrut pathway. This could be easily corrected with just pulling back the wire, putting the balloon, correcting, and this is the 3D again after correction of the pathology. So my take-home message for you, my dear colleagues and friends, the issue, as I said, is not IVUS versus OCT. It is intravascular imaging versus angiography. Choose any eye modality that you want, master it, use it, and then you will do okay. And please remember that angiography is not enough. Thank you so much, and remember to put on your glasses. Thank you.